Great. Well, thank you all for joining, and welcome to this really special Melbourne Design Week edition of the Open Labs Online called Design and Health Beyond the Status Quo. My name's Nithya Solomon. I'm the Deputy Director of the RMIT Health Transformation Lab. I would like to acknowledge the Wurundjeri people of Kulin Nation, on whose unceded lands the university stands, and we who are physically here for the webinar are gathered today, but also would like to acknowledge the traditional custodians of any lands that you might also be dialing in from, and pay my respects to all the elders past, present and emerging. We have a really exciting session today. It's called Design and Health Beyond the Status Quo, and really what we're looking to do in this session is highlight work that is forging interesting and unexpected collaborations between design fields and the health system or healthcare sector more broadly. We are looking to offer some interesting provocations for new ways of working in these intersections between health and design. We've got some amazing guests who will be sharing examples of their cutting edge work. So Kellyanne McKercher and Chelsea Lang, and we'll have formal introductions shortly. And then we'll also be, during the session, having some questions that we will throw out to all of you to respond to with an option to contribute comments or thoughts via the chat function. So you should see on the bottom right-hand side of the screen, if you are dialing in from a physical laptop or computer, a bubble icon for chat. There is also a Q&A function as well if you want to submit more comments. We won't actually be having a Q&A per se in that traditional sense, but if you do write in the Q&A, your comments will be visible to everyone. If you use the chat function, you can choose to have your comments visible to us as the organisers. So with that, I'm really pleased to then get started, and if we could move on to the next that slide, please. So I'd just like to tell you a little bit about the RMIT Health Transformation Lab. We are really set up to and really looking at health in a very broad way, but really set up as a path-breaking collaboration with Cisco Systems and Melbourne Innovation Districts to create an Australian first health transformation lab that was really existing to curate, create and design to fill a void that was both experiential and substance-based within the actual health system. And in particular, we are set up to design for the future of health in a new way by addressing issues around fragmentation, by looking at ways to bring in new types of imagination and insight and creativity, but also look at what it actually means to build new interconnections in a health system. And if we could go to the next slide, please. And then perhaps the next one after that. It's worth acknowledging that when we talk about health, in terms of how health is being defined, it's helpful to go back to even how the World Health, or particularly how the World Health Organization defines health. And this is really a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. And sometimes it's easy to default to health being hospital systems or health being particular models of providing care or particular environments, but looking at definitions like this of health that are so broad and encompassing offers really huge potential in terms of how fields like design, but really creative problem solving can help at the end of the day create better outcomes for people and communities. So with the next slide, please. As I mentioned before, the RMIT Health Transformation Lab was set up as quite an exciting industry partnership between the RMIT University, Cisco Systems and the Melbourne Innovation District. So it's probably hard to see from this particular image, but really we were set up as a place where we could really operate at the intersection of design, health and innovation to solve in new ways and test the solution of some really challenging problems in health. And there really hasn't ever been a better time to think radically and disruptively about what needs to change within the health system, and in particular when you view through the lens of design. So we are a place where we generate insights, we prototype solutions, we look at the interfaces between humans and technologies. We look at the interfaces between, the machine and what it means to be socially connected. We solve for inclusion. We're definitely driven by the science of systems and digital insights, but also can be a gateway into the breadth of RMIT University, which is exciting. As someone who's worked in innovation for a long time, it's quite common to come across motivations of solving tricky problems and designing, but I think it's important to then put some of these words and concepts into real practical demonstrations of what could be achieved in really working in different ways. So I've got a couple of examples to share with you now. So if we go to the next slide. This is, and you might have seen a similar picture in the event information for this session. This is a really exciting prototype that was tested out here at the space, and it's called the drone cheese. So what it is I think really interesting to look at the shift from drone use, commonly associated with surveillance, to what could be the potential as a mindfulness teaching aid. So the device, and you could probably see that the drone in between the person's hands there, but it's beautifully designed, flower-shaped casing, so really having a lot of aesthetic in the design. But what it's doing is trying to, with the use of that device, replicate some of the qualities that you would get in an in-person Tai Chi or mindfulness class experience, but really have that be able to be replicated in situations where physical in-person interaction can't happen. And in particular and we've all gotten to experience some of the limitations of the 2 dimensions of the Zoom screens. What the drone actually allows you to do in a much more improved fashion is generate 3-dimensional insights about how the person is moving and collect some very customized observations that could then get fed back to the teacher. Now, this is something that wasn't, when it was designed, really envisaged to be the answer to health system problems. But actually, when you look at the potential in terms of the lives that we're living now post-pandemic, it's just got a huge potential in terms of how models of virtualized care and virtualized delivery could really be significantly enhanced to overcome some of the limitations that we have with the use of screens and different applications for technology, which is exciting. So lots of fields of design there at play, but really very powerful types of solutions in terms of new ways of creating and delivering health in the future. So then the next example that I wanted to share, if we could move to the next slide, please. This is something that we call the cat pin brooch at the Conversation at Therapy, and it's in just early stages of prototyping and piloting at the moment. This is, and what you see there is a physical brooch that's pinned on a wearer. What lies underneath that casing is some pretty sophisticated technology that's really looking to analyze speech and conversation patterns and see if there are links between the amount of speech and conversation that happens and loneliness. And so this is something that we're prototyping and trialing in an elderly setting, where we're looking to have a wearable device that's got some pretty sophisticated voice types of capture behind it, and then combine that with the ability to link speech and interactions to feelings of loneliness and social connection, with the idea that in an ideal world, if once those links are there, that certain nudges could be put into action to promote social interaction if it was seen that levels were falling low. And so you may not tell by looking at this, but a world of usability and wearability design has gone into it. We've got a huge amount of in the mental well-being space, looking at social interactions and how they can be made sense of in the very customized world of individuals who one is very different to another. but then supported by machine learning process, which take a different type of design lens to altogether. So the combining of all of these is something that we're really excited about taking through to prototype. But another example of how practically we are looking at ways to do these experiments that merge different fields of design and information science and data analytics together, but in very humanized ways. And then the final piece that I wanted to share with you, if we move to the next slide, and again to give a glimpse of moving from more micro, highly personalized types of experiences, something, another style of way that we here at the Health Transformation Lab think it's really important to look at the future of health, but the ability to take more of a very big picture macro systems perspective. And what you see here on the screen is a recent piece of work that the lab did around COVID time and really looking at the transformation of the citizen in a post-COVID world. And while this content was very specific to the disruption that happened during the pandemic, there are, when you step back and think about it, some pretty exciting opportunities that disruption actually offers in terms of the nudges that we've already been given to look at redesigning systems in a very different way. So for example, you'll see at the top left-hand corner the mention of new dynamics of information, trust and attention. So a huge burden on individuals to navigate for themselves in an unprecedented way, copious volumes of information, to know who to trust and what to do to manage their own conditions. And it's not a role that was necessarily placed on individuals with such onus before in a health systems perspective. But I guess now that we've had the experience with this rethink of information architecture, it offers a huge amount of potential in terms of future opportunities to think about how information does flow within a system level and how to really navigate the quality of information along with the trust considerations as well. And I suppose a couple of other things to highlight here, I won't necessarily read through all of them in the time that we have here today, but also wanted to highlight the one at the very bottom in terms of the new embeddedness. So suddenly we've gone from defaults around the way we live being very globalized to then suddenly having to be hyper localized. And in that abrupt shift, huge opportunities from a design perspective in terms of models of the future to really rethink what the design possibilities might be as it relates to supply chain, how we source, how we live, married with, the last box there on the bottom right, the facing into uncertainty. So the amount of uncertainty that we have experienced in the most basic areas of life do offer some new considerations on when we're designing in the future for health, how we can make ourselves more adaptable to these levels of uncertainties and actually intentionally build in navigating through uncertain times as an intentional piece of design. So these are just some little glimpses of work that we do at the Health Transformation Lab that represent some areas where we feel are opportunities to go well beyond the status quo, and some of our thoughts on what excites us moving into the future. And if we could have the next slide, please. In terms of most of the conversation today, to really take a deep dive into what does that mean for the design community, we really are, really broad with how we would like to think of the role of design. So right through from industrial design to architecture to urban design, you name it. So, there's design happening at so many different levels, but really exciting to think about then how do we meaningfully weave in some exceptionally sophisticated principles, but bring them together in a comprehensive way, but at the end of the day, really think about how processes of discovery can support better outcomes for people and community. And if we can have the next slide, we're about to move into hearing from some others soon, but this is the first of the questions that we'd love to throw out to all of you who are on the line today. Just interested to hear from you on this particular question. How does the health sector currently intersect with your field of design? And if you're joining the call but you're not in a field of design, just whatever field that you are in, what are the intersections between health and your field? And I would love for you to provide and share any comments you have via the chat function. And as we progress through the session, would take the opportunity to read some of those out and play them back to you as well. So while you have a think about that, I'm really delighted to now hand over to Charlotte Fligner, who is the Innovation Fellow at the Health Transformation Lab, to lead the next part of this conversation.
Thank you, Nithya. And today I'm delighted to lead the second part of our conversation, which is with two panelists who are both designers working in or with the healthcare and health sector. First, I'm delighted to introduce Kellyanne McKercher. If you can just pop on your camera, please, Kellyanne. Kellyanne is the Innovation Portfolio Lead at New South Wales Health Pathology, where they lead the innovation agenda to design healthcare based on equity-centred principles. Kellyanne is a leader in design and particularly co-design in the Australian design community, and they have recently developed a wealth of design resources, including the writing and publication of a book named Beyond Sticky Notes, which you'll find on Kellyanne's website and social media pages. However, more recently, Kellyanne has been leading a series of conversations with leaders from across design and health to map out the landscape of these two sectors. So we are really happy to have Kellyanne join us here today to share some of those insights, research and learnings. So first, Kellyanne, before I let you introduce yourself, can I just also pose a question to you, which is, with your background in design anthropology and your current role leading New South Wales Pathology's innovation efforts, can you describe what you mean when we talk about design, especially in the context of health?
Yeah, just a casual question to start off with. So look, I think design is the rendering of more care across our systems, whatever they be, and that the way we do that is through, various means, be it visuals, products, services, systems, or changes in cultural and social norms. And I've got some very concrete examples today to share about, I guess, design's specific role. And sort of demystifying some of the things that we're talking about, be it design or be it the status quo.
And so in your role, how do you bring design to that, to the organisation?
So a range of design projects where we're, I guess, showing to the organisation and showing to the broader system what it might mean to lead a human-centred design project or a patient-centred design project. We might be demonstrating something that's more in the co-design or co-production space. We might be building capability around the mindsets of design, and that being an important precursor to then really getting value out of the methods of design, which are not very helpful if we take over lots of sort of traditional or business as usual thinking into something that is fundamentally trying to be different, feel different, and engage differently.
And then if you think about your role in New South Wales Health Pathology, and you can give us a bit of an insight into working as an insider in the health system, what does the status quo look like to you or to someone in the health system? And what might the design profession and how you described your own role in that help to change the status quo?
Well, I actually have a slide about this. So I don't know if that is maybe meaningful to go to that. So I'm sort of not talking randomly or abstractly.
Yes, please.
So I guess when I'm thinking about the status quo, I'm thinking about this swirl of the way things are, that are often produced and reproduced over time. So these are things like accepting who gets to make decisions or who is excluded from decision making. These are things like what we permit and what we promote in our systems and our workplaces and our teams. These are things like the types of inequalities that we, I would say, actively tolerate, and we might talk about wanting them to be different, but might not apply specific equity-centered design practices into reducing that inequality or promoting equity. There are a whole bunch of real and imagined boundaries that we draw for ourselves across systems, and barriers that are both real and perceived to doing something differently. And I think it's important to respect that there are things that are real and are not imagined, and are complexities that we are sort of having to contend with. There's then, I think, some norms around a solutionism, or a kind of moving straight to how we want to solve something without, I guess, assessing what the problem is in the first place. If there is in fact a problem, according to whom and who wants it to be solved. And then I guess there's a whole bunch of confirmation bias that we might set about restricting the types of questions that we're asking and answering. And we might, for example, only ask people about their experience of care in a particular setting, but not ask them whether they even wanted to receive care in that place in the first place, and whether there might actually be alternatives. I think it's also important, though, to be really respectful of the fact that our health systems are full of really dedicated people, many of whom share in the hopes and frustrations of the status quo as it is and what could be. And many of these people are also constantly rationalizing the gap between how we all believe things could be and how they are now. So I guess design is one particular technique in which we can benefit from those hopes and frustrations, and provide a kind of pathway and a mechanism to do something with that. So if we move to the next slide, what we're really suggesting here is that design makes the invisible visible. And through doing this, it allows the status quo, as I currently mentioned it before, and you might have a different perception of what the status quo is, to be discussed, to be rearranged, and possibly to be disrupted. And one of the primary ways that a designer or someone enthusiastic about design or tasked with design can do this is simply through the time to stand still, to observe, and to unpack. And when we're at the front lines of delivering healthcare, the ability to take that time, to be provided that time, is something that is often a luxury that just cannot be accessed. So design is almost an introduction of a function that allows us to do that. And if we move on to the next slide, some additional things that I heard from design leaders across, really across the world, across Australia, I know some of you are on the call today, is that how design makes the invisible visible is through visualizing, is through remixing what is known and creating shared meaning through having objects, diagrams, discussions, experiences. Through a design research approach, we are really creating insight where there was often only information. So for example, we might know how many people access a service, but we don't know anything about their experiences. We might know how many people come to our service, but we don't know who's missing out and why it is that they weren't even able to access something in the first place. Design or in my practice and expression, being fundamentally participatory is something that also engages people in their own discovery and captures their own curiosity about that gap between how things are and how they could be. And in that way, I guess this is the potential for it to be less affronting than showing up and saying, hey, I've got a better idea for you. And I guess most importantly, in what puts the design, and for example, co-design, is that we're also creating tangible prototypes of alternative futures, alternative objects, alternative systems, alternative services. And this fuels both action, where we are stuck, and we have in many places become stuck, but it also provides a really rich learning experience for staff, for communities, for academic partners, for whomever. And if we move on to the next slide, something I was really asking in this kind of conversation with a whole bunch of, and it's not just designers, but also people who are design enthusiasts, who are senior executives leading design, who are clinicians. I was really asking the question of what is it that's holding us back and what is it that's moving us forward in terms of really embracing the potential of design, particularly I would suggest more participatory forms of designing, service design, systems design. What is holding us back is worshipping at the cult of technology. So we are so fixated on this idea that technology is going to come and, you know, fix what may in some places be a very complex system. And in that, we completely miss the relational aspects of health and of care. And if we're always pursuing technological solutions, the relational is always left out. And this means going into a process willing to not have the answer be an app, a website, a product. And this is I believe, a really terrible inheritance of a sort of Silicon Valley type mindset of what design is and what is possible. It needs to be said that we are failing to engage with design professionals across health systems across the world to assist with both design and co-design. It is really difficult to do co-design without the design part. We are very much underappreciating the unlearning and the shift in dominant logic needed if we're going to move from some of the ways that we have worked, and I'll say what those are very shortly, into what design asks of us by way of mindsets and methods. We are, as many different areas, are stuck in this mutual misunderstanding where we're not quite understanding each other, where we have pockets of brilliant examples of where design is creating outcomes, but our general coherence as an industry is holding us back. We're not always good at explaining the benefits of design or engaging people in enough of the complexity to see this as a rich field without confusing them with all the different types of versions and tools that are possible. And we are very much rushing to the work, to the workshop, to the deliverable, and we are not investing and moving, as Adrienne Marie Brown says, at the speed of trust. So in saying what is holding us back, what is moving us forward? Really, design as a senior leadership function is creating authorizing environments all around the world in public health and private to not only ensure that design is, I guess, at the table, that design professionals are brought in, but also that we don't just think design is a job for designers, and we are also kind of embracing the partnership of citizens and communities and families. But it's really hard to lead a kind of thriving design or co-design function without that more senior role of having really good sort of subject matter understanding, as we do with other fields. There is an unhelpful thing we are also doing where we are overstressing and overstating the potential for visual and product design to address the scale of challenges that we face inside the health system. I'm not suggesting that better visuals, better forms, and better products aren't needed, but alone they will not transform the system, and we cannot pretend they will. But what I'm seeing as being really helpful in different places in Australia, at home, in Aotearoa, and internationally, is where we have what Dan Hill is terming a kind of strategic design sensibility, where we use that product as a portal to a different kind of conversation about a different kind of future. But in that, we must then hold the strategic and the particular at the same time, and not get too focused or obsessed in finessing a particular product and not then using it as a catalyst for a broader conversation and a broader imagination. We are still not consistently seeing that if design and innovation are not equity centered in their processes or in their outcomes, are they even very good design or innovation? We are being moved forward very much when we commit to learning as a key outcome of exploration, when we don't say that every design process must work, because it just will not, but rather we commit to the learning experience of that and kind of harvesting or composting what hasn't worked. And really, I think what matters is for design to be embedded in the reality of healthcare, not to sit in ivory towers with, you know, beanbags and post-it notes, but rather to come into and meaningfully understand the very real constraints that many of our colleagues face delivering care and delivering accelerating demands on care. So if we move to the next slide, and there's just two more things to say here. The first one I wanted to say is this unlearning and relearning that we're not always talking about or appreciating. And this visual aims to say is that what it can appear like in the surface is that we are enacting, we are rehearsing, we are performing different ways of being design. But what is then bubbling underneath the surface is a whole bunch of inheritance or status quo that is not named and then is played out in a process that we have termed something different, but is a masquerade of the same. And that is, for example, looking to homogeneity and blanket solutions, one worldview as opposed to plurality. We cannot treat design with this kind of hyper focus as we have inherited from some project management disciplines, where we're so focused on our time frames and our deliverables and getting things done, we're not necessarily responding to what emerges, and we may not even be assessing outcomes over outputs. We sometimes get stuck in wanting people to behave, to be more acceptable to us, to show up to where we are, instead of considering, for example, that systems are not, people are not hard to reach, but systems are hard to access. And that is our responsibility to take that on, not ask individuals to do more and more and more, often when they are unable to do that. We can very much move into parenting people, being very paternalistic, saying that we know best what is for them. We can get fixated on quick fixes and magic bullets, and in a complex system, there is no such thing as a magic bullet. There is not one thing, and there is certainly not one app that is going to transform the system. And there are many more things here around getting stuck in problems and not looking enough at strengths and opportunities, getting stuck in binaries and competition, and trying to save people as opposed to recognizing that people have the answers about their own lives, and we need to create the context for learning. So on our final slide here, I've been thinking a bit, and I'm not all the way there, and there's lots more to do, is what is beyond mutual misunderstanding? I think that design as strategy, as doing, can create a pathway to move our organizations from words such as innovative models or patient-centered models into deeds and into meaningful relationships. But to do that, there has to be a partnership of content knowledge or context and clinical knowledge with lived experience and with design knowledge. And we're often not bringing those three things to bear. And there's probably more circles in this Venn. Beyond mutual misunderstanding, we focus very much on mindsets and sharing mindsets before we move into methods, which can very much turn into co-design performance or design performance. We must kind of balance the technical with the relational innovation and keep coming back to, I guess, what is human and what care is about, because care is very much about the relational and the technical is probably a support to that. But we have to do a few things differently. So as designers, we have to stop over-promising. We have to stop using language like design will solve the world's problems, or as a particular agency claimed recently, will fix capitalism, which is just not a thing. Let's be really honest about that. We have a meaningful and a helpful contribution to make, but that it needs to be made alongside other contributions, and it won't always work, particularly when the conditions of a system or organization may not be ready or ripe for a particular process or outcome to succeed. And that requires a little bit more humility and a bit more listening before we start offering our design tools, and a meaningful engagement with complexity, not trying to oversimplify what isn't simple. And on the health professionals lens, something that can really support in getting involved in a design process is increasing capacity for ambiguity, increasing our ability to share power, particularly with people with lived experience in communities. And given this is Melbourne Design Week, it would be really ridiculous not to say we must elevate our understanding of design as a profession and as a practice. And that if we want to have more of it and see more of it, we must welcome more designers into our systems.
Thank you, Kellyanne. That's a fantastic call to action, I think, to all of the designers, but also the healthcare professionals who are joining us today. And I especially like that you finish off with that diagram of those three elements coming together, because I think that's a really good segue to Chelsea Lang and her work and how she can provide us today with some really practical examples of how her work at Ylab has brought those three sectors together. So we are really happy to have Chelsea join us, probably from one of the many co-working spaces she's been doing the tours of lately. And Chelsea is a director at Ylab, which is the consulting arm of the Foundation for Young Australians. She is a designer with a background in social work and now leads Ylab's health and wellbeing work. We are happy to have her here today to talk about her experiences as a designer working with the healthcare sector, but also her experience in leading and training young people to also work at this intersection of design and health. Welcome, Chelsea. And I know we have some limited time, so I think I'll just jump straight in and ask, what does what does design mean to Ylab, and how has Ylab adopted design as really core to its organisation and its way of working?
Thanks, Charlotte. I'll potentially never forgive you for putting me after Kellyanne, but I will give this a solid crack. I am Chelsea. I'm a director at Ylab, which, yes, is a social enterprise born out of the Foundation for Young Australians back in 2016. And your question was, what does design mean to Ylab, and how have we adopted co-design as core to the organisation? Our organisation in its core is a co-design business. So we train and employ over 70 young people from really diverse lived experiences, cultures, identities and backgrounds to co-design solutions or responses to systems issues that they've come up against in their lives. We've done this across many systems, so everything from employment to housing to First Nations justice, democracy, and then of course some deep work that I've been doing in the health and wellbeing space. So we bring together, oh sorry, go for it, Charlotte.
No, keep going.
Yeah, we bring together young people with relevant lived experience, as well as clients and partners and other technical experts to do this work. So it's so awesome to hear Kellyanne describe that in that final slide. I'm saying, yes, we must be doing some things right.
Yes, and Chelsea and I started actually chatting to each other and talking about Ylab's project with Origin, which she's going to present today. Can you talk us through the project, your approach, some of the outcomes?
Yeah, sure. So this is our third year collaborating with Origin now, which has been pretty incredible to build that trust and transparency in our co-design work with them. A little context might be helpful before I go into our approach. In Melbourne and actually across Australia, the supply of beds for young people who need access to acute mental health care does not currently meet demand. This has been identified through the Royal Commission into Victoria's mental health system, but also has been identified from young people that are in our networks and our associate team at Ylab across Australia as well. So in April, the Victorian government funded 15 new beds for young people with acute needs. But the difference with these beds was that they would be accessible for young people in their residences. So care would come to them. It's a really excellent idea, but it's also something that's quite complex to successfully implement. And there are a few reasons for that. So I'll take you through that before going to our approach. One, it's a logistical nightmare to get, and quite the task to get the rhythms and roles and responsibilities, as well as policies and safety structures in place for a hospital in the home model to be effective. But at the same time, and as importantly, providing acute mental health care in a young person's home is an incredibly intimate way to interact with them, as well as those who care and support for them at their most vulnerable times. And then when you add a system with its own issues, again identified in the Royal Commission, lack of cultural safety, fragmentation, appropriate workforce supply issues, and a strong need for decolonised and intersectional approaches to care, it's a pretty big task to build something that will meet this need effectively. So we came on board, and you can see there that we also asked our friends at the Australian Centre for Social Innovation to come on board to co-design key elements of this model for care that was going to be implemented by Orygen. So our approach is as follows, and you can see it on the screen. We employed a team of 5 young people who have lived experience of accessing acute mental health services to lead this work, along with family and carers, health professionals, and of course, people with co-design expertise to support the process. We then engaged a further 30 young people, families and carers and health professionals to understand their current experiences of inpatient care, but to also hear about their hopes about what the Orygen at-home model could actually look like. We synthesised these findings and shared them back with both Orygen and the Royal Melbourne Hospital teams, along with co-design participants. And that was to make sure that we were really affirming what we were learning, and our interpretations were being validated, and we weren't just saying what we think needs to be said, but actually what young people and family and carers and health professionals are experiencing and want to experience. We then conducted a series of workshops to bring these insights and ideas together, test and iterate on those ideas, and develop model principles and mindsets, and then finally share our final outputs and recommendations with Orygen and the Royal Melbourne Hospital to operationalise and implement. You asked something about outcomes, I think, and this work is still being finalised, but there are some outcomes that I can speak to that I think would be really helpful in this conversation. The first is that young people who were on the associate team have actually been employed now by Orygen, which means that they can take that co-design knowledge and experience with them and embed it in the system. The Orygen crew have really developed their kind of confidence and knowledge about co-design. I'm sure some people on this call know that co-design is an extremely trendy term to be using at the moment. And so to see organisations and individuals talk confidently about what it actually is has meant that some real magic has been able to happen. And then finally, we've been able to develop some really clear and strong principles and mindsets for Orygen to implement in the model. And that's to kind of make the most of the unique approach that they've got and support care teams to disrupt the loop of multiple admissions for young people accessing this care, but also to ensure that young people and their families and carers feel really respected and safe and confident to invite Orygen at home into their homes and into their worlds.
And it sounds like from how you kind of fostered this really collaborative team with Taxi and with the hospital and with Orygen, you'd have some really practical experiences in working with healthcare professionals, and also from Kellyanne's presentation, where she had that ladder that quickly kind of skipped over at the top, was changing culture. Design and healthcare traditionally have very different cultures and ideas around ways of working around risk, safety, quality, experimentation, health being quite risk averse versus design's experimentation culture. Do you have any tips for designers who are collaborating or building collaborations like this, kind of bridging that kind of cultural gap?
It's a very good question. I have many responses, but I will give you 3. The first is that I think that investing in excellent facilitation can't be underestimated in this work. It's so important to not only ensure that the process is well guided and connected, but also ensure that the power shifting that's necessary for real co-design work is actually happening, particularly in healthcare settings. And I don't mean it's just about facilitating like workshops or sessions. It's also about facilitating conversations and connections and collaborations. And we talk at Ylab a lot about facilitation a key skill is being able to be both on the balcony and on the stage at the same time. So being able to take that balcony view and see all of the movements that are happening to get us to some goals that we have or objectives that we have for the design work, but then also being able to be super present on the stage and really listen to what people with lived experience and technical expertise are saying. The second is transparency is a massive one that we've learned through our work in health and wellbeing. We recognise that sometimes there just are constraints that really need to be taken into consideration that are non-negotiable. So it could be legal constraints or funding constraints or duty of care when working with young people. And so for everyone on the co-design team to be able to get clear on what's in scope and what's not means that people can be really confident and aligned in the work and not feel like they've been kind of brought in to tick a box or to be the token young person with lived experience, but actually they're really important to the work. And then the final one is supporting people with ambiguity. And this is probably the trickiest one of them all. Yeah, there's a lot of fear, I think, actually, and it's well-founded fear of sitting in a problem or testing different ideas and being okay with things not working or needing to start again. The risks in healthcare can be extreme, but we have seen some incredible results by healthcare professionals and teams and even organisations who have the ability to sit in the mess for a little bit, of course, with a really excellent risk management plan in place, and just get that chance to explore and get creative and think about the question, how might we actually make things better? And I think we learned that a lot through this Hospital in the Home project, because we all kind of moved through that ambiguity together and developed some really strong relationships as well.
Thank you, Chelsea. Thanks very much for joining us. If you can please just flick the next slide, please. Now I'll throw out to everyone our next question. Here we go. So if you can see on screen, if we can grab your responses in the chat box again, to what are your ideas for how your field of design can create a different health system for the future, after surely being provoked by Kellyanne and Chelsea. And when you have a think about that and write your responses, I'll just throw the camera back to Nithya. Thank you.
Great, thanks, Charlotte, and once again, thanks, Kellyanne and Chelsea. Just amazing to hear your examples, and it's interesting. And thanks to everyone who's already submitted quite a few comments through and questions through the chat function. Interesting to note only the breadth of people that we've got on the call. So, you know, from people studying architecture to people working at regulators to the mental health system. So there's a lot of diversity in who's on the call, and interesting that there's a lot of commonality in terms of the comments with I mean, certainly questions around co-design and acknowledging that the appeal of it when done well, yet the limitations, as has been mentioned already, of you know, not allowing the time to get it right. And really interesting to see some great comments coming through in terms of, I guess, really coming down to how do you think about designing to really help people at a very individual level, and when you can visualize a you know, a particular customized set of circumstances, how that can lead to better outcomes than sort of generic categorizations that may not actually work for any specific situation in that, you know, that well. So really great to see the comments coming through there, and also the range of settings that people are working with, from you know, where, you know, need to be trauma sensitive is important, right through to how the built environment can encourage health and well-being. So thanks for all those questions. And there was also a question on timing about when we were going to conclude. So we started a couple of minutes after 3, but we'll aim to wrap this up just 1 or 2 minutes after 4. So we'll be pretty sharp about time there. what I'd love to do now is give you all a bit of a sneak peek, by way of closing, I guess, a little bit of a sneak peek into something we're about to launch soon officially in the coming months here at the Health Transformation Lab. And if we could have the next slide, please. This is something that we're for now calling the RMIT Cisco Sandbox. It's a bit of an understated name for what could be, we feel quite excited about as a potentially huge disruption as it relates to these intersections between design and health and the like. So, what you see on the screen is a visualization of an environment, which is kind of the cube in the middle, where you can imagine a physical space that has the ability to bring through collaborations that could involve, designers, technologists, healthcare leaders, policymakers, practitioners, but also researchers and academics. What we're actually trying to do is set up a simulated clinical environment so that research and development can occur in a way that's removed from the settings where care is actually being delivered and doesn't have to interrupt those processes. It's a place to prototype some significantly potentially out of the box ideas, but really rethink the possibilities of how data and human interactions can occur throughout the health delivery chain. So I'm going to show you some pictures in a minute that will look a bit more exciting than the beautifully designed cube that someone has drawn. But I think what we're really wanting to do is create some physical spaces where you can imagine we've got some state-of-the-art technology from Cisco, monitors, tablets with movement sensors, cameras that can, in a physical space, actually set up an information architecture around that can help us and our collaborators be able to test different ways of delivering care, I guess. So if we could go to the next slide, the first image that I wanted to show to you all is the physical space that we're creating around the waiting environment. And of course, we're now in models of health delivery where we're not always physically there and there's telehealth, but there still is this concept of a waiting time before your primary interaction. And the exciting question is how, what are the possibilities here to really, test what types of meaningful interactions could happen between service providers and users, and what could those interactions look like. So in this particular space that we've designed in the picture, you'll see, more well-being geared physical layout, but also the ability to have tablets and even, visual detection cameras that could, really provide new solutions of how contactless care and, the care process could already start to happen pretty significantly even while you're waiting. So that's kind of one environment. The next environment, if we could move to the next slide, please, is some physical space that has been set up to look at how could doctor-patient kind of interactions be really transformed. So again, you'll see monitors, you'll see deliberate use of design aesthetic to look at how physical space could nudge a different tone of conversation potentially. In a world where there's already virtual care and distributed health models, how could information come real time in that particular conversation and in that moment to just get comprehensive data all kind of right there at that point of having the interaction with the doctor, for example. And then the third environment, if we move to the next slide, is a bit of a glimpse on how the space that's been created to test how the actual care delivery and, more like the in-hospital or akin to in-hospital experience could be transformed. And again, you'll see the hospital bed, you'll see the monitors, but what kind of sits behind this is an interactive space, again, for real-time personalized care to be, and how that's done to be prototyped. So just really reimagining the way that not only patients experiencing care, but also visitors to this environment, clinicians, facility staff can all kind of interact with each other. And really looking at how information flows, who can access what data, cutting down lag times and receiving information, but ultimately that, the possibilities to test different ways for all of these types of environments and parts within the health system to work with each other is what we're really excited to be able to do with collaborators in this sandbox space. So we're very excited for that to be kind of ready to be operational soon. But and when it is, we'd love to share the news and information with you all, and figure out a way to be able to show the space to you as well. Now we've got 3 minutes left until 4 o'clock, but we do have one last question by way of a question back to you all as an audience, and particularly with your design hats on and what you've seen this type of a sandbox environment. Very curious and interested to hear from you in terms of what design experiments could you see yourself or others prototyping in an environment like this, where the physical space has been set up, a technology infrastructure has been set up, but then there's pretty much open space to really explore and test, I guess. So love to hear any thoughts that you have by way of the chat function. And I wonder if I might also ask, in maybe 30 seconds, brief comment, final comment from Chelsea and Kellyanne, also in response to this question, in terms of what kind of comes to mind for you in terms of some really meaningful opportunities to prototype or test in this environment. And perhaps I might actually ask Chelsea first, so that Kellyanne can follow you this time, but just short top of mind ideas on what you could see as being exciting to prototype in an environment like this.
I appreciate going first. Thank you very much. For me, I think something that we were really looking for was the ability to create a home environment for clinicians, young people, to walk clinicians and staff members through, and so they could really understand what the experiences are of a young person within those environments, and how to be as respectful as possible. So yeah, I think that would be mine. Kellyanne?
I'm just going to support what Chelsea has said, actually, in saying I'm not sure the future of healthcare is going to be in traditional health environments and as much in hospitals or in waiting rooms. So I actually wonder if it's really about what our home environments are like, our community environments are like, and how some of this becomes a kind of invisible but helpful actor in that, as opposed to testing out really just new orientations of technology, but within the same paradigm of you have to come to us.
No, that's great. Absolutely. Wonderful. Thank you so much. And also a quick comment coming in through in terms of a point of view from an anthropologist and ethnographer, and design thinking, just sharing the amount of scope that there does exist in understanding some intersecting contexts and interactions. So great. So really appreciate that, and feel free to still submit any thoughts or suggestions through the chat. But otherwise, I will wrap up the session and bring us to a close. Really want to, of course, thank Melbourne Design Week for the opportunity to be part of the program this year. Huge thanks to Kellyanne and Chelsea for sharing your perspectives and very deep insights about the work that you do, but some of the opportunities for the future. To Charlotte, the co-facilitator here at the Health Transformation Lab, but also Jess and Nico, who behind the scenes have been doing a lot to produce this event, and finally to all of you for attending. So we look forward to sharing some recap and notes with you after this event. And thanks so much for your contributions and for the ideas submitted through the chat, and hope you'll have a lovely rest of the evening.